Hello and welcome back. In this part two, we're going to talk about two primary learner objectives. We're going to describe how the FDA indications vary for currently available devices, so we're going to review those a little bit. We're going to talk about how insurers such as Medicare might have different indications for who can receive a cochlear implant, and then insurers might have separate indications. And then we're going to look at other issues related to implant candidacy. So let's first look at FDA indications. We know that they're often developed following completion of a clinical trial. They're important. They're guidelines for us. They're not laws. So they're meant to help guide our best practices. And they really guide our decisions as well as important insurance companies' decisions regarding who's considered to be a cochlear implant candidate. And because they're included as part of the device's label or they're placed on their packaging, when we choose to implant outside of those indications, that's why it's called off-label. So if we look at FDA-approved indications, they typically include statements about the degree and severity of the hearing loss, as well as statements about speech recognition and the amount of benefit someone can receive from hearing aids. And if changes are made to the device after the trial, which happens a lot, the manufacturer submits a supplement for approval. And currently available devices have had lots of supplements, and you can actually access all of those if you're interested on the FDA website. But one thing that's like really highly misunderstood is that the FDA indications currently vary greatly for the more traditional devices. So on this slide, just as an example, if we look specifically at audiometric thresholds for Advanced Bionics Cochlear Med-L, for adults and children, you'll see that if we look at the audiometric thresholds, they range from bilateral severe to profound, to bilateral moderate to profound in the lows and profound in the highs, to bilateral severe to profound. It's similarly different for children, bilateral severe to bilateral profound. And so it's kind of hard to keep track of this based on the actual device. But more importantly, we'll talk about in a few minutes is looking at the specific insurers' indications, and that sometimes helps provide us with clarity as to what are we supposed to follow. If we look at the audiometrics for hybrid and EAS, we know that we got a lot more lenient because those devices demonstrated the ability to preserve the residual hearing. So for the hybrid device, it states normal to moderate hearing loss in the lows and severe to profound mid to high frequency hearing loss. And for Med-L EAS, it's normal hearing to moderate sensory neural hearing loss in the lows and a severe to profound mid to high frequency hearing loss. If we look at the traditional audiograms, one thing I like to think of is when I started working with implants, we really looked for people that had an audiogram, a corner audiogram in the bottom left. And now what we're finding, hybrid and EAS, but if we overlaid this onto here, really the upper right is the area that we need to pay attention to because the whole rest of the audiogram is sort of open game for implants. Patients whose audiograms fall in there could theoretically qualify for an implant, but they likely won't qualify if they have hearing in the upper right-hand side of the audiogram. So along with those audiometrics, we've got speech perception. Those vary greatly too. Again, we've got the three devices. Some of them are outdated and need to be updated. They'll either look at specific materials. Sometimes they don't specify the material, such as hint sentences that need to be administered, or the MLNT, PBK, or hint C, as we see down here for children. And really just this example is to show you how variable they are for the different manufacturers, and that's really based upon when they received FDA approval. So the earlier the approval, or the longer ago that they received approval, probably stricter the FDA was on the indications. If we look at hybrid and EAS, there's a couple of important things. This is the first time we went towards looking more specifically at the ear to be implanted and less at the best aided, which I love that hybrid and EAS brought that into our field, because for too long we've been looking at best aided. We should really look at the ear that we're treating. So for cochlear, it says between 10 to 60% in the ear to be implanted. And believe you me, I was like shocked. I was like, I can implant somebody with an implant that scores like 60% on CNCs in the implanted ear. And then they want to make sure that they've got some hearing loss in the other ear. So it needs to be a CNC score not better than 80% correct in the opposite ear. Med-L is 60% or less in the ear to be implanted and in the contralateral ear. So what this tells us is we're looking more at words rather than sentences. Words tend to be a little bit harder, and that's actually a good thing. But more importantly, we're looking at the specific ear to implant. If we look at the FDA's recent approval for Med-L for single-sided deafness and asymmetric hearing loss, which occurred in July 2019, big step for our profession. So SSDs, they state they have a profound sensory neural hearing loss in one ear and normal hearing, or a mild sensory neural hearing loss in the other ear. Where asymmetric, they need to have a difference of at least 15 dB in the pure tone averages between the two ears. But this is great because honestly, these patients need cochlear implants. What we're also seeing is that indications might differ if the manufacturer is conducting a clinical trial. So what will happen is if they're looking at expanding their indications, they need FDA approval, or they'll need to have an IDE approved in order to use those different indications for that trial. So for an example, when the 532 was going through its clinical trial, instead of the 50% and 60% on sentences that they had in their more traditional devices, they stated indications as limited benefit from amplification by test scores of 40% correct or less in the ear to be implanted on monosyllabic words and 50% or less in the contralateral ear. So because this was not touted as a hearing preservation device, the FDA was a little bit more strict on the hearing in the contralateral ear as well as on the ear to be implanted. Indications might differ depending upon the patient's insurance. So if you Google some Blue Cross Blue Shield policies, you're going to find that the wording can be different. This is an example of, they still haven't dropped it down to 9 months. Theirs is still 12 months and older. Bilateral severe to profound, so that's worse than moderate to profound. They specify a pure tone average, which if you remember when we looked at those indications, nobody cited a pure tone average, but Blue Cross does. And here continued score 50% correct or less in the ear to be implanted, but it doesn't really say anything about the best aided. So there's a trade-off there, correct? In children, limited benefit is defined as failure to develop basic auditory skills and less than 30% correct on open set tests. So because of all of this variability, at the University of Michigan, we started requesting that we receive a copy of the patient's benefits. So we had it for a while where we got that prior to the appointment so I could review them. And then I knew what their insurer said I had to meet, or the patient had to meet, in order to be considered a candidate for a cochlear implant. And that was so helpful because if you do it after the appointment, you really can't counsel the patient regarding if they're truly a candidate based on their insurance. You can counsel them based on your recommendation, but then you might need to let them know later on that it will require a special letter or peer-to-peer review or different things. Some insurers have their own requirements, such as Medicare. Even though Medicare is a federally based organization like the FDA, it's really primarily an insurance company, where FDA is a regulatory body. So it's federally funded insurance, and they can determine what they'll pay for. So like most of the other indications, they require a moderate to profound sensory neural hearing loss, but they're more stringent. They require test scores of less than or equal to 40% correct in the best aided listening condition. They do expand that out to patients can score less than 60% in their best aided condition and less than 50% in the ear to be implanted if they're in an approved clinical trial, but that means that whoever's performing that clinical trial has to get approval from Medicare to be considered that Part B there for those indications. And with Medicare, the biggest challenge is it's difficult or impossible to pre-authorize if it's Medicare Part A and B. If they have a Advantage plan, then it's a little bit different, and we'll talk about that in that third bullet point. But if a patient's test results fall outside of Medicare guidelines, you could petition your local Medicare administrative contractor or your local MAC to request an exception to that 40% score in order to seek approval for the procedure. Some clinics haven't had such good outcomes doing that, so they elect not to do that. They hold stringent to that 40%. Now, if a patient has doesn't have traditional Medicare, but has a Medicare managed plan, or what's also sometimes referred to as a Medicare Advantage plan, they will often require the implant center to pre-authorize the procedure. So their indications might follow Medicare, or they might follow the indications of the managing plan, the insurer who's managing it. So like a Humana Advantage plan or a Blue Cross Advantage plan, they might follow the Blue Cross policy. So it's really important for you to know your patient, know if they have straight Medicare, if they have a managed care plan, and if they have a managed care plan, what are those indications that their insurance requires. The good thing about those Advantage plans is if they don't meet those, you can often contact them and ask them to approve it, even though they might not meet their specific requirements. So do you need to adhere to the FDA indications? Well, it really depends. It depends on the patient's insurance. And in their benefit plan, insurance might state a variety of things. You might see that all they say is that the patient must meet FDA indications. Well, right there, you need to go look up the device you plan on implanting and make sure that they meet those FDA indications. They might have their own requirements, like we showed you with Blue Cross or Medicare, that are different from those of the FDA. Some might refuse to pre-authorize and say, read our manual, follow our guidelines. If you implant outside our guidelines and we find that you did that, we won't pay. So if you can't pre-authorize, then you're really stuck. If you feel someone outside those guidelines is a good candidate. Some insurers will actually review the audiometric test results before they'll provide you with authorization, and they're kind of doing a double check on your work to make sure that they meet the criteria. And some will consider pre-authorizing even if the patient does not meet their stated candidacy requirements. And what that typically means is that you're able to send a letter or to request a peer-to-peer where the surgeon can meet with the medical director of the insurance company in order to discuss it before they'll say, no, we won't pre-authorize this procedure. So we're all becoming insurance experts on top of being audiology cochlear implant experts. If a patient does not meet FDA or insurer indications, again, those are not laws, they're guidelines. So you can consider providing implants off-label. And as we've expanded out to people with more residual hearing and the indications haven't been updated like they should have been, clinics are a lot more likely to implant and recommend devices off-label than they have in the past. But even the FDA recognizes that some patients should receive a product even though they don't meet the approved labeling and indications. And I love that. I love that the FDA puts this out there because it lets us exercise our clinical judgment. And the FDA states that good medical practice and the best interests of the patient require that physicians use legally available drugs, biologics, and devices according to their best knowledge and judgment. And if they do use a product for an indication not in the approved labeling, they have the responsibility to be well informed about the product, really to make sure that you're making a good judgment call for that patient and to base its use on firm scientific rationale and sound medical evidence. So it's important for us when we go off label to track that, to report it, and to share the information gained from doing that with other clinicians. So it's also important to remember that some insurers will not consider off-label. So if you have somebody that's scoring 50% in their best data and you think, well, I think they're a good candidate, I'm going to implant them anyways, you could really put your clinic at risk because if you implant outside those specified indications, the insurer could refuse payment. And I think your hospital might say, well, we're not going to pay for it then, and they'll bill the patient for that. And that really wouldn't be fair to patients that we've misled them and we haven't done due diligence before we provided them with an implant. And with Medicare, the center places themselves at risk for denial of payment as well as at risk for an audit. And seriously at risk for potentially receiving large fines if a patient receives an implant who does not meet their approved indications. And that's unless the procedure has been approved by the local MAC. But if they do an audit and find out that you're implanting outside their guidelines, you could be at risk for fines. So just so you know, we're trying to level the playing field for those patients over the age of 65, and in accordance with the American Cochlear Implant Alliance, CMS approved a CED, a coverage with evidence development study, to consider expanding indications for its beneficiaries. It's been a 7-year-long procedure, and we're still fighting for it. Criteria for the study include bilateral moderate to profound hearing loss, but it is looking to expand criteria from 40% up to 60%. You can read more about that study on the link there. And right now, in October of 2020, we submitted a request to open the NCD, which is the National Coverage Determination, in order for them to look at the data collected in this study and to provide us with information as to whether or not they'll consider expanding their indications up to 60%. So stay tuned on that. This is just some data from that CMS CED study. The centers that participated are listed there on the left-hand side. And then this just shows some of their scores preoperatively versus their best aided at 6 and 12 months. So, what you see are these 3 scores preoperatively. And then nice improvement in all 3 scores post-implant. So we feel as though we've got a very good shot at changing those indications. At least we're hopeful for that. If you look at speech recognition requirements, you'll see, so an example is Medicare. Really, their indications just state test score is less than or equal to 40% correct in the best aided listening condition on tape recorded tests of sentences. But they give no specific mentions of which sentence test material you need to use. And we know that AZ-Bio sentences are a lot harder than hints. So most clinics will use AZ-Bio sentences because the scores will be lower, but they're also more representative of sentences that we might encounter in our daily lives. There's no specific mention of presentation level. Most clinics are using 60, but I think if you checked with clinics, you'll find that there are some using 50, there's some using 65 or 70. And most importantly, as we discussed in part 1, there's no specific mention of presentation mode. So some clinics, their protocols state that they'll base candidacy on their sentence score in quiet. Others will do it at +10, and others will do it at +5. And we're kind of all over the board. So a patient might get denied an implant at a clinic that's using +10, and then they might go down the street and be tested the very next day at a clinic using +5 and meet candidacy requirements. So there's a lot of variability out there. But the lack of clarity or lack of clearly defined things in the indications leaves quite a room for professional judgment, and I love that because it takes so long for those indications to get updated. So what we're doing is we're changing our standard of care, and then we're applying it using our professional judgment to change the materials and the presentation modes that we're using. But all this variability we're talking about shows how important it is to have clinical protocols so that centers can follow their protocols with all patients regardless of their insurance, and that all clinicians within a clinic can be on the same page in terms of deciding about candidacy. One other thing I wanted to mention is that with some clinical trials, it brought this to light. And plus, as we're implanting patients with more hearing, and we're including patients with more low frequency hearing specifically, we're finding that if we stick real strongly to 40 dB as being a moderate indication, that we're going to lose some patients in terms of candidacy, maybe just because they have an island of hearing at 125 or 250. So if we look at, for example, Medicare stating that they need a bilateral moderate to profound hearing loss in the low frequencies and a profound loss in the mid to high frequencies, some centers will use a pure tone average of low frequencies and mid to high frequencies. So for this audiogram, when we were, students, we would describe this probably as a mild to profound hearing loss. Well, if we look instead and develop a pure tone average for the low frequencies, we would come up with a PTA of 45 dB for the lows, which would fall within the moderate range. And definitely in the high frequencies, we have a pure tone average of 95. So then they would meet the moderate to profound. So we'll talk a little bit more about this in the live lecture, but it's one area that clinics are changing and sort of updating how they're looking at the audiometric thresholds to make them fit better with the clients that we're seeing in the clinic. So for example, here's a sample patient. In clinics, we typically administer more than one test, and we typically test the right and the left ear separately as well as together. And really, the best aided will vary from clinic to clinic. Sometimes people will refer to the best aided as the best score in the ear that they're planning on implanting, and other clinics will call best aided the best score when they compare, let's say, the sentences or the words for the right ear alone, the left ear alone, and then both ears implanted together. So your interpretation is going to depend on the test materials or the test situation used. So if we look at this example, we find that the patient meets the Medicare criteria of 40% correct if the protocol is to test in noise. So first we look at what's their best aided, and if we're going to go right ear, left ear, and both together, we find out that both together is the best. So that was then repeated in noise, and they're less than 40%. So if that clinic sets their bar at that plus 10 as the cutoff, then this person would meet Medicare criteria. If this clinic doesn't test in noise, then they would find that the best aided was 59%. This person would meet FDA indications, but would not meet Medicare indications. And so if they had private insurance, they'd probably be able to get the implant. And if they had Medicare, they would be denied. So it's really important to decide what column you're going to use as your bar. Is it going to be the plus 10? Is it going to be a plus 5? Or is it going to be sentences in quiet? Using all those together and being on the same page with your clinicians, there's so many questions that come up. So what do we do about all this variability? Well, I think it's really valuable to establish a documented test protocol that defines the test materials that your center uses to determine candidacy. So you'll want to think about what test materials, especially what sentence material are you going to use with adults. Are you going to include CNCs? What's going to be your presentation level? Are you going to do testing in noise or just quiet? If you're going to use testing in noise, what noise level are you going to use? I always recommend that you document everything appropriately and thoroughly in the patient's chart, including all tests performed. I've had new clinicians come up to me and go, okay, so this patient didn't meet it in quiet, but they met it in noise. Should I still include the quiet scores? And I say, if you tested it, you include it. And if you're basing your decision knowing how well they did in quiet, but you're basing your decision on the score in noise, then your report needs to reflect that. So I think it gives us information about how they do in quiet, but that's not being used for that determination of candidacy. So your report needs to say that our clinic bases candidacy on a test in noise administered at plus 10 or plus 5. If candidacy is unclear, I recommend discussing that issue at one of your team meetings, and then you document the meeting and the decision in the patient's chart. So if you've got a form that you can fill out, or someone can do a chart note indicating who was present, who discussed it, because if you get audited later on, you don't want to be the sole person held responsible for that decision. If you take it to the team and the entire team decided, then the team is the one that's responsible for that decision, and not just you as a sole audiologist, or not just the surgeon and independently making that decision. And really, when you're developing your protocol, I believe pretty strongly that the test procedures used with the patient should not be dependent on their type of insurance. So you shouldn't use a plus 5 with Medicare and a plus 10 with everyone else because Medicare is stricter. You should determine when you think someone is a good candidate and which test measures help you decide that. So what if someone with private insurance doesn't meet criteria? Well, always check their insurance. If you don't check that and you implant them anyways and they haven't met their indications, you might not receive payment, and that could be a mess for the patient. Our protocol, like I mentioned previously, includes discussion of the patient at a team meeting if the patient does not meet traditional criteria, and then we document that. The physician can request a peer-to-peer discussion or review if the approval is denied. We find those to be highly successful. So if we find a patient that we think is really good and what's keeping them from getting an implant is their best aided situation, but that ear is profound, we can reason with a medical director of an insurance company in a peer-to-peer with the surgeon, and we've had fairly good success with doing that. And then your special letters, sometimes you don't even need to peer-to-peer. Sometimes you could just submit a special letter, but they have to be clearly written. And in our clinic, the audiologist takes them upon themselves because sometimes we're better at describing the audiometrics. And remember to describe it in a way that the insurance people can understand, because they might not be familiar with audiometric testing or with cochlear implant candidacy. So there's all these expansions, right? And we're not playing the system. We're just changing what we do based on the population that we're seeing and based on the outcomes that we're getting with patients. So these expansions are really appropriate. FDA approval signifies recognition that a hybrid or EAS array is more likely to result in preserved residual hearing than a traditional implant. So patients with greater preoperative hearing can benefit from CI technology. So with that approval, they acknowledged that the indications should be changed, especially when the device can give more hearing. But now we find that patients are able to use their acoustic hearing if it's preserved, even if it's not a hybrid or EAS device. So those patients where we can preserve it, all processors are now available that utilize acoustic and electric hearing in the same ear. Those are available if we're able to preserve hearing with a non-hybrid or non-EAS. So really, the approval for SSD and AAHL more recently indicates greater recognition of treating the impaired ear and less emphasis on that best aided condition. So these are great expansions, but we're not where we need to be just yet. It's really time to expand current indications. Patients are doing well with implants. Most are scoring more than 60% on 80% on sentences and 60% on words. They do even better when we add in the hearing that they have in that contralateral ear, be it normal hearing with an SSD patient, but more likely a hearing aid on a patient, a more traditional implant patient. Lots of patients are being implanted outside FDA guidelines. A lot of patients are being implanted off-label or with special permission from the insurance company, which is so important. And they're doing well, and that's really what's important. And Renee Gifford demonstrated in her article in 2008 that current measures, even back then and now are even current ones today, lack appropriate sensitivity. So clinicians often make modifications to current test batteries to increase their sensitivity and make them more applicable in today's world of patients. Lots of patients are being considered for off-label. Single-sided deafness, if you have a patient, if let's say, for example, your clinic doesn't do med-el devices, you can implant SSD, but you might have to ask the insurance company for permission to provide a patient with an AB device or a cochlear device that doesn't have FDA approval for SSD and AHL. Asymmetric progressive hearing loss, we've been actually asking for approval for insurers to do that for a very long time, especially if a child has EVA or CMV, and we know that better ear was what was keeping them away from candidacy, and that better ear will likely progress. So we'd like to implant them sooner rather than waiting for that better ear to drop. A lot of clinics are implanting prior to 12 or prior to 9 months of age, where the FDA says that we can. And for a long time, we've been implanting children with auditory neuropathy, where they sometimes or often have better pure tone thresholds than we might, than the FDA indications we reviewed might see. All right, so we're going to finish up with our last learner objective. So hang in there with me. I know this is a lot to hear, especially for the first module, but we're just going to talk about some other issues related to implant candidacy. We're going to review test protocols, a little bit about bilaterals, and some issues related to billing and coding. So I'm going to take you through the University of Michigan test protocol and show you how helpful it is to have a protocol. And we have a separate protocol for adults and a separate protocol for children. And we have separate protocols for preoperative testing as well as separate protocols for postoperative testing. We have these posted up in our sound booths and we follow them faithfully. The other important thing we do is we review them very regularly to make certain that they remain current and that we all agree and that we're all using them in the same way and we're understanding our interpretation that we're all on the same page. So we begin with that unaided audiometric testing, which we have up here in this very top box, verification of hearing aids. And if they're not meeting targets, we'll fit them with a clinic aid that is optimal. We'll start with bilateral aided AZ bios, and we'll do that in quiet. At 60 dB SPM, we'll do one list. And the reason for that is sometimes, I'm sure you see this, within 5 minutes, I might go, I don't think you're an implant candidate. So the first thing I'm going to do is start with quiet. If they're going to be less than 60% with traditional insurance or less than 40% with Medicare and quiet, I'm going to take them down the path here on the left because they'll be a traditional candidate, and that means that they're probably going to be less involved in that testing, and they're probably a pretty straightforward candidate. If their bilateral aided score is greater than 60%, then I'm going to do some additional testing. And I'm going to start to do bilateral aided testing with AZ bio sentences at a plus 10 dB signal to noise ratio. And if their score at plus 10 is less than or equal to 60% for private insurance, meaning I'm looking at the FDA indications or what their insurance dictates, they're less than 40% on Medicare, I'm going to then say you're a candidate, and I'm going to go through our regular test battery, and I'm going to administer CNCs in quiet, and I might do AZ bios in quiet in each ear as well. And then I can use those scores to help determine which ear I want to recommend the implant for. And we might want to do something like if the poorer ear is greater than 40% on AZ bio and quiet, we might want to talk to them about the possible loss of speech recognition, possible loss of residual hearing, because they probably have some hearing left if they've got that speech recognition score. Improvement in hearing, so we would say, you know, most of our patients are scoring above 80, you're at 40, let's hope that we can get you up to 80. It's a very different story than if I have someone scoring 0, because it's pretty straightforward that we're going to likely improve. But we'll also talk about their other ear and how we would like their bimodal score to be even greater, and how putting an implant in that ear with some speech recognition will let it use the other ear together and will more than likely have a bimodal score. If they score above 60%, we're going to go down this other side, and we're going to just do more testing, because really what we're trying to decide here is, okay, they are outside the indications, but maybe there's still a chance that they're a candidate. So we're going to do this additional testing, and those are the patients, if at the end of the appointment, you know, I've had people start to cry and say, I'm a teacher, I'm going to quit my job, I'm going to go on unemployment. I can't function this way. And so we talk to them, and it depends on how close they are. If they're at 61%, you know, or if they, in the best aided, they're at 65%, but they have a dead ear, that is probably someone we're going to ask for off-label for, especially if that dead ear was deafened recently. So we're not going to rule anybody out. We're really going to look at all of the situations, and we're going to then bring them over here to consider requests for off-label. Inclusion in a potential study, maybe we're doing a study that has different indications that we could get them involved with, especially if they have Medicare. Sometimes we can get them an implant that way. Similarly, with our pediatric patients, one thing to keep in mind is we have this SLP evaluation, and that helps us in our overall decision. So has it been completed? And yes. Is it normal gains or a moderate delay, or is there a mild delay or a severe to profound delay? So that's going to help weigh in our decision. So with the kids, the older children, babies are, you know, we don't do speech recognition, so this would apply to the older school-age children probably, or someone maybe with a progressive loss. We're going to do a best aided MLNT or LNT, and we'll typically start at a plus 10 signal to noise ratio. Remember, that's still better than what they're typically getting in a classroom. And again, we're going to go down to the left side. We would proceed as a traditional candidate if they score less than 30% on the MLNT or LNT, because the FDA indications cite 30%. But if their score is greater than 30%, we're not going to send them away. We're going to do additional testing. And again, we're going to do their best aided, and we might make it more difficult and present it at a plus 5 dB at 60 dB SPL. If at 5 dB, that's sort of our bar, then we'll go and we'll test the left aided, right aided, and we'll do some additional testing that will help us determine which ear to be implanted. Are we going to proceed with an implant in their poor ear, or are we going to do it in their better hearing ear? Or are we going to take them to a CI team meeting in order to discuss it with the team before making a recommendation? If their score is higher than that, we're going to do what we did similarly with the adults. We're going to take it to a team meeting. We're going to really involve the speech language pathologist and see how even though there are outside indications, maybe they're still struggling with speech and language, and that's a reason to proceed. So all of these really help you go through the process to decide if you'd like to recommend a cochlear implant. Just some tidbits that we have found really helpful as we keep track of all these preoperative test sessions and the process in the chart. So we have this, and then it carries over from report to report, and the audiologist indicates on this form the date that it was completed, so that way we make sure that all of our testing has been done, including the radiology, the surgeon, and then we indicate when it's ready to submit, and if it is, then that's when we send it to our insurance person to start the pre-authorization process. We also track hearing aid billing in the chart, because a lot of times we will be fitting, especially children, with a hearing aid as part of the process, especially if we get them following identification via ABR, and we're fitting them with their first hearing aid. So this is just something you might find helpful to use in your chart as well. With hybrid EAS, you're going to get a great lecture on this specifically, so I won't talk about it too much, but things that we look at: should we put in a hybrid EAS, or should we give them a more traditional electrode array? Is looking at, are they dissatisfied with their hearing aids? How stable is the hearing loss? If it's progressive, we might want to wait and watch, or place a longer array in and try to preserve hearing in case that hearing loss progresses. And don't forget about those AZ Bio sentences. If you have someone that's scoring less than 40% or less than 60% and they're meeting traditional indications, that can help you decide if you should go with a traditional implant or a more traditional electrode array, or if you should go with that hybrid EAS. Other considerations for adults are bilaterals. I would say in our practice, simultaneous bilaterals are standard of care for children with bilateral severe to profound hearing loss. Adults tend to go one ear at a time, and then when they're comfortable with that first ear, then we go back sequentially with that second ear. Medicare is unclear about its coverage of bilateral implants. It's unclear, does best aided mean if you've got an implant in one ear and a hearing aid in the other, that best aided includes that implant, which when a lot of those patients are scoring more than 40, that would take them out of candidacy. So some clinics say, nope, I don't base it on their implant, I only base it on the hearing aid score. So again, those are protocols that you need to decide in your clinic. Sometimes they'll go outside that 40% for a medical reason, or just focus on the ear rather than the best aided. But again, remember to discuss it with your team and have a straightforward policy for all your Medicare AB patients, your Part A, Part B, and think about what your message is to those patients. But we did a survey recently and found that vast majority of clinics, yours is likely included, will provide a bilateral implant to Medicare beneficiaries. And when they do that, it's regardless of what the score is in the implant ear. So they're just looking at the ear to implant. And on your reference list is an article by Mediri et al., where they recommend testing all patients in both quiet and noise. If even your poor performers, it sometimes feels kind of mean to do that, but preoperatively, and then you can actually see the improvement that you'll get post-implant with your battery. The lack of clarity about bilaterals with Medicare can complicate your decision. Sometimes people will say, well, I'm going to recommend your poor ear first, and if that doesn't turn out well, then we can implant your better ear later. But that's backfired for us on a few patients, because they don't do well with that first ear, and then they say, you're not touching my better ear, even though their better ear is still a candidate. So think about that, and I think most clinics are moving towards implanting bilaterals with Medicare patients, and that should make it less of a big deal. So what if your adult has no health insurance? Well, they might want to consider a disability evaluation under Social Security. There was actually a group of experts recently convened to look at this. You can look at the links here, but know that they might change. And then there's additional information on the AAC8 website regarding how to help patients with no health insurance find coverage for a cochlear implant. And I really think that this disability is way overlooked by cochlear implant audiologists. I recommend you become familiar with it for both adults and children. I won't go through these because they're listed. They're pretty lengthy, but they're listed. You'll get a copy of these slides, and I recommend you become familiar with them because you might have patients with no insurance who might qualify for disability, who could get a cochlear implant, get their hearing back, and then get a job and not be on disability, which is sort of the goal. Children can qualify for SSI as well, so please look at those as well and be familiar with them for children. We're going to finish up with information about billing and coding. And remember, this is provided for example only, because I think one of the more complicated things, and you'll find throughout this course, we've asked instructors to touch on billing and coding. And in the very last module, we're going to talk about it in depth. That billing procedures will vary depending upon your particular setting, and your selection of code should be discussed with your individual billing department or billing expert. But I know it's a sort of an area of confusion for a lot of programs about, well, how do I bill for this? And what is the code 926 meant to include? So I'm just going to show you what we've done at the University of Michigan. And these are the codes that we typically use for preoperative testing for adults and children. CPT 92557 is a comprehensive audiogram, but remember, if you do that, you need to do the unaided speech recognition. So a lot of times if you get a really deaf person and you say, I'm going to be testing their speech recognition aided anyways. Well, if you don't do unaided speech recognition, you should be using 92553 because that one states that no speech recognition is performed. You'll get reimbursed less if you bill 92553. So I recommend that you do 92557 because you'll sometimes see a disconnect between unaided speech recognition and aided speech recognition. Not to get a higher reimbursement, it's just something that's quick and more comprehensive. So we tend to perform 92557 as part of our protocol. Tympanometry, acoustic reflex testing, and then the tricky part comes with 92626 and 92627. But as you proceed through this course, you'll become more familiar with the CCCI edits, and those will tell you, those were developed by Medicare with the AMA to tell you if you could bill certain things on the same day. And if you do bill certain things on the same day, will you get paid for both? Well, sometimes you won't. Sometimes they'll only pay for one, no matter how many procedures you do. So it's really good to become familiar with the CCI edits, and there will be information about that posted on on Blackboard. So if we look at those codes we just had previously, all of these, then we have 92626 and 92627 at the bottom. So most speech recognition testing performed with CI recipients, either preoperatively or postoperatively, will be coded as 92626, and the descriptor is evaluation of auditory rehabilitation status. And this code was recently revamped, and it specifically applies to patients with implantable devices. And I've posted a resource there that I recommend all of you read, and it talks about specifically things that can be included in 92626, and it'll make you feel better about some of the things I'm telling you that we do at the University of Michigan. So 92626 is a time-based code, and it represents the first hour of testing that you spend with your patient. In order to use this code, because it's time-based, you must spend a minimum of 50% of that time. So for a 60-minute code, you need to spend at least 31 minutes, so 1 minute over the 50%, in order to perform the procedure, and you also need to document your start and end time when you bill for this procedure. If the time spent performing the procedures associated with 92626 exceed an hour, so let's say you spent 75 minutes doing speech recognition testing and other things, then CPT 92627 should also be billed, and that will cover those additional 15 minutes. So if you spend 1.5 hours of testing, you bill 1 unit of 92626 to cover that hour, and then 2 units of 92627 in order to cover that additional 30 minutes. So at the University of Michigan, we included the following when we determined the amount of time spent for 92626. And then if we went over an hour, which typically we did preoperatively, the remainder of the time for these procedures would be associated with 92627. So probe microphone measures could be billed as 92594 or 5, but instead we take those times that spent doing those and we roll those into 92626, as well as the listening check of the hearing aids, because remember, we're evaluating their rehabilitation status, but in order to do that, we have to make certain that their hearing aids are fit appropriately. If we are going to spend time programming a clinic stock hearing aid, if we're going to do functional gain with that appropriate amplification, if we're going to do an SDT, an SRT, all of our aided speech perception testing, and also if we're going to administer any questionnaires or even obtainment of case history. So when I talk to a person about the cause of their hearing loss and how long they've worn hearing aids, all of that is going into my decision, and it's part of my evaluation of their oral rehabilitation status. So hopefully that's a tidbit that will help you with your billing and coding. So in terms of this determination of candidacies, clinicians need to make decisions according to their best knowledge and judgment. And this really includes the decisions that you and your team make about test materials, presentation levels, candidacy decisions. Those decisions should be based on firm scientific rationale and on good medical evidence, and should be made by clinicians who are familiar with the product. Does that sound familiar? It comes from those FDA, that FDA wording. We should perform similar testing pre and post implant in order to obtain a realistic picture of what patients with implants can and cannot do. It's not good for us to determine candidacy based on a +5 signal to noise ratio when we have no idea the typical score that's obtained by implant patients with a +5 signal to noise ratio. So really the post-op helps us with our internal gauge of what's appropriate. There are some great billing references that I've listed here. Those are the articles, and they'll be posted on the board, on Blackboard, and their references are here. So I'm going to conclude this first module. Thank you so much for your attention. I really look forward to discussing these issues when we meet for the live online discussion. And then also, please check your discussion board, because we'll have some questions where you can all comment and share with each other about all of the things related to determination of candidacy that you're experiencing in your clinic. So thank you for your time.